welcome to the PCNA Webinar Wednesday. My name is Megan Day and I'm a member of the PCNA Webinar Working Committee. And I'd like to firstly acknowledge the traditional owners of country throughout Australia and recognise the continuing connection to land, waters and cultures. And I pay my respects to elders past, present and emerging. And today I'm on Gadigal land of the Eora Nation. So these sessions are designed to support palliative care nurses and broader health service by providing access to contemporary learning, practical insights and conversations led by national leaders in palliative care education. So today's session is Tricky to Navigate Symptoms, Managing Itch, and we'll cover causes, assessment, pharmacological, non-pharmacological management, and strategies to improve patient comfort. So before we begin, a few quick housekeeping notes. Please use the chat function to share your comments or ask any questions throughout the session. And we ask that you remain respectful in your interactions with one another and of course our presenters. We'll have question time at the end of the presentation and we'll work through as many questions as we can from the chat as possible, so feel free to put them in. This session is being recorded for those who registered and will be shared afterwards. And also we'd really appreciate your feedback via the survey that will be sent at the end of the webinar. So today we're delighted to be joined by Josh Cohen, nurse practitioner and senior lecturer at Flinders University, and Robert Wojnar, palliative care pharmacist, who will be presenting on itch. Josh, thanks for joining us today. Can I ask you first of all, what's the background? What causes itch in palliative care patients?
The cause of itch. Okay.
Just a small one.
Well, I thought before I jump into the cause, just firstly, where did I get my information from? So by no means am I an expert. We can't be experts at everything, but I went to CareSearch and they've got a review section where they've sort of reviewed all the recent evidence. And I found in there, I'm just going to have a quick look here because I had it open before. If you go into your review collection under the systematic review collections, and they've usually got all the different symptoms there. They've got a whole bunch of things. There was a section there on pruritus, and they've got going from 2025 right going back through the years. So I went there first. I also went to PubMed and put in, pruritus, itch, everything, all the words you could think for itch, palliative care, hospice care, terminal care, and then assessment, and then you get a whole bunch of things from there, and you can, make the search smaller through English only and the last 5 years or something. That's another good place to go. And it was really those two sources that I went to. And also the palliative care formulary, which I think a lot of people would have access to through their workplace. And in there they have specific sections, and thankfully there was a section there on pruritus as well. I think mainly because it can be a really tricky symptom to have to manage, and usually, takes a community to manage it of clinicians, not just the one person. And the other thing I thought I'd just talk to is, how common is it that we have to manage itch? And we probably all have a different experience of it, but there certainly is a prevalence of it, anywhere from sort of 2 to 85% of the patients that we see. We know that itch or pruritus, I'm going to say it a lot because I've been practicing how to say pruritus, it's multifactorial in origin, like a lot of our symptoms, and it can be through diverse pathophysiology, and we'll touch a little bit on that, but as I say, I'm not an expert of that, but I can certainly give you some idea of what's happened. The type of patients that I think most people would associate with itch are patients with hematological cancers. Certainly 30% of people with Hodgkin's disease, I think 3% of non-Hodgkin's disease, lymphoma, leukemia, anecdotal experience of people with those hematological malignancies that will, especially cutaneous lymphomas, will have itch. Solid tumours also, any malignancy can cause itch. So I guess it's always good to have in the background of that it could be a presenting symptom. In terms of solid tumours, you have a paraneoplastic pruritus. And sometimes that can precede a diagnosis of a cancer by months and years as well, which I wasn't aware of. The pathophysiology of that pruritus is not well understood, but it's certainly an immunologic reaction to tumour-specific antigens. In terms of, that's our cancer population, and we know that's a cohort that we see. In terms of non-malignant presentations, we know there's obviously people with chronic kidney disease, CKD, uremic itch. That's something that we very commonly have to manage, and some of the non-pharmacological ways of managing that I'm sure we'll talk to. Cholestatic pruritus as well, which can be from a non-malignant and a malignant cause. With uremic patients, we know that up to 42% of those patients who are on maintenance dialysis will have itch at one time or another. I think it's gotten less as dialysis has gotten better. And with cholestatic pruritus, 100% of the patients with a biliary cirrhosis may present with itch, and up to half of those may present with that to begin with. People with HIV, end-stage disease, sometimes over 20% of those people will have itch. And then for our palliative care patients, just more generally, a bit of a broad brushstroke. We know as patients in the last weeks of life, as organ failure sets in, so certainly kidney and renal failure, systemic itch can become a real issue, can become a problem as the organ function changes and gets worse. It can have a wide variation amongst the patient population, and also anxiety can play a big part, especially toward the end of life as well, in the management of itch. So it certainly requires an interdisciplinary response, and it might be a referral to dermatology depending on the trajectory, the illness trajectory of that particular person, where they're up to. Certainly palliative care nurses were often in there managing a lot of the non-pharmacological things, and wound care potentially as well. Then the next big question might be around the quality of life for those people and how it affects quality of life. And I guess that the literature says it can certainly have a very significant effect on quality of life. In terms of it can exacerbate social isolation, there's the psychological distress, there's the lack of sleep, which tends to come on at night. People don't sleep very well. And that can then make people fatigued, which can make everything seem a lot worse. And it can sort of add on to already the existing symptom burden that these people have, and adding to their psychological stressors as well. Sorry, Megan, I can't. Are you talking there?
I was just trying to mute someone else. Sorry about that. Do you think, just because obviously this is something that often comes up with our patients, in regards to itch in patients with, say, morphine or other opioids, etc., what's your experience, and how do you explore that with or support patients and their families with those sorts of issues?
You mean itch from
Yes.
an allergic reaction to an opioid?
Well, itch or not so much allergic reaction, but reported sort of side effects that people feel. Have you had experience in sort of managing those situations?
So around opioids and itch?
Yes.
Is that?
Yes, correct. Sorry.
Yes, look, I think we all have.
Yes.
And often that might involve then a rotation to a different opioid. But through reading, I found that I was surprised actually that the prevalence of morphine and itch, it's not as much as we think.
No.
Often itch and opioids are for opioid naive patients. And certainly patients that have had surgeries and might be having a block and an opioid in terms of that as well. A lot of those patients, up to 80% apparently, can experience itch. Our patients that have been on opioids for some time, so less of those are going to experience itch. But certainly then what I was saying before, toward end of life, when you have change in renal function, change in liver function, itch may become a problem then as well. And certainly opioids might be one of those reasons. Occasionally you have a patient that is opioid naive, that you start on opioids and they have an instant reaction, to, for example, to oxycodone. And then you might rotate them to morphine or the other way round. But I'm not convinced through reading what I have read that opioids and itch are as closely associated as we think. We tend to just jump to it, I think. And be interesting to see what other people think about that as well. But yeah, that would be my experience of that.
Fantastic. And how would you go about assessment or differential diagnosis of itch, to sort of, what's your approach?
Yeah, look, that's a good idea. And I guess that if we talk about, you know, where you would start in your assessment of these patients, and the first thing you might think, well, what tools will I assess? First one that came to mind for me is just a symptom severity score, and get some information from the patient about how it's affecting their day-to-day life, their quality of life. And it also then makes us realize what is the most pressing need for this person on this particular day, and it may very well be itch. And then automatically you're beginning to think, well, what could be the cause? Of course, before we see any of our patients, we are aware of their life-limiting illnesses. Some patients will come with pre-existing skin conditions. So itch may have been a part of their life, or pruritus may have been part of their life for some time. Some people might have, you know, dual diagnoses of renal failure and liver cirrhosis, for example. So you are certainly going to be wondering about which is causing, you know, what, or what's causing what. And I guess in understanding what's causing and what, we have to understand the pathophysiology, and perhaps we'll come to that in a second. But in terms of the assessment that's required, it's certainly a holistic approach that's required, and will require symptom relief, and may also, and most likely, require good skin care. So a physical examination, to have a look at the skin. We know the skin is the largest organ on the body, so you're going to have a look at it. Is there redness? Is there dryness? Is there scratches? Are there lesions? And certainly, you know, if someone has had chemotherapy or radiation or immunotherapy, then there's sitters for dry skin, for burns, for immunologic reactions that may happen when they're receiving the treatment or further down the track. So those things are going to be red flags, if you like. In terms of what you might be assessing. You'll be having a look at the color of the skin, the texture of the skin, the temperature of the skin. Questions, and these are questions that you might ask for a lot of symptoms, but certainly for pruritus, you know, when did it start? How long does it last? How bad is it? What part of the body is itchy? And I think it's also, and we'll come back to this when we talk about pathophysiology, a definition of itch or pruritus. I think that's an important foundation for someone to have. How does the pruritus affect your activities of daily living? What makes it better? What makes it worse? Are there any other family members that have itch if you're in someone's home? Do they have pets? Are there allergies? Those sorts of basic things that you might ask. Have they had pruritus before, and how did they manage it at the time? And then, of course, the big one is medications, because we know that any medication can cause an allergic reaction. So what medications are they on? Have there been any changes? Changes in diet, their social history, you know, their general skin care, their emotional health. And then you'd be looking at pathology as well. Liver function, kidney function, thyroid function, lactate, a full blood count. And depending on the severity of the itch, you may be doing more invasive things like a skin biopsy, referring to dermatology for that. You may be wanting some imaging as well, in terms of, you know, organs. So, you know, you want to check the skin barrier and manage that, and then assess from there. So it is, as you know, we've discussed, it is quite a holistic assessment. For someone with itch. I know when we come across a patient who has pruritus, I think a lot of our first reaction is, oh, this is going to be so hard to manage, where to do it. But if you just begin to do some of those simple things that mightn't feel very meaningful in the first instance, they actually are quite meaningful and will add to the story for that person.
Definitely. How do you approach itch then across different settings, whether it's in community or in inpatient, and would you find it usually chronic or more episodic in your experience?
Well, I think that comes down to a definition of what itch is. And we know itch, it's an unpleasant sensation that elicits the urge to scratch. I'm feeling itchy now. And we know that then scratching, that can then, that stimulates a response in and of itself, which might temporarily relieve the itching through, through the actual itching that I'm doing now. And the actual sensation of the itch may depend on the location of the receptors and neural excitation. And this is part of the story around the pathophysiology of itch. And itch is, or pruritus, as classified as either acute and what you were saying before, chronic. Acute is less than 6 weeks for itch, and chronic persists for longer than 6 weeks. So people may have, had this itch for a long time before they were admitted to a palliative care service. So I guess that needs to be established. And then we know, as we were saying, that the causes can be multifactorial, from dermatological situations, systemic, neurological, and psychogenic conditions. Did you want me to talk a little bit to the mechanism of itch?
Yeah, would that be possible, or more?
Well, I can try. There are probably people.
Or would you define it first for us then, if we go back to that?
Can I what? Sorry.
Oh, did you want to feel that you need to define more what itch or pruritus is?
Well, I think I've given it a definition.
Yes, beautiful.
It's a pretty simple one, and it's. I think it's always good to have that sort of in your toolkit to know what it is. But then, of course, we are going to be thinking, well, what's the cause? What's the mechanism of the itch? And that can be the hard part, because the pathophysiology is potentially not well understood. And we know it can be a complex interaction between the nervous system and the immune system. And I don't know, when I was at uni, the immune response and the cascade of responses is always very complex. But I think the transmission of itch is similar to the transmission of pain. And often pain and itch you can have them concurrently. So the way that it's transmitted and understood by us, it's a similar transmission of communication, if you like, that pain is. So it's sensory nerve fibers in the skin, particularly C fibers. Once again, C fibers and pain. They're stimulated by how do you pronounce it? Puritogens. Sorry, puritogens. There you go, puritogens, which in turn induce itch. Similar nerve pathways as for pain. And the puritogens are chemical mediators, if you like, that act on nerve fibers. And some example of the puritogens you'll know: histamines, hence antihistamines, proteases, cytokines, and neuropeptides. They're the things that transmit the signal, the thalamus to the spinothalamic tract and up to the brain, which then leads to the perception of the itch. So I guess that also, I'm sure Robert will talk to blocking those communication channels through medications. And then it's a cascade of a media release after that. There are two pathways for itch. There's a histamine dependent and a histamine independent pathway. So there are two distinct pathways for the perception of itch. The histamine dependent one is the one that you have, for example, an allergic reaction, or often in oncology setting, patients are getting treatment and suddenly they feel a huge intense itch and rash. That's probably the histamine dependent itch, and that's triggered by mast cell degranulation. And then you've got the histamine independent, which is the more systemic itch. peripheral and central, if you like. So peripheral is the histamine dependent and the central is the histamine independent. And that involves cytokines, proteases, those other pruritogens that we were talking to before. And an example of that would be itch from chronic kidney disease. And then I guess we offer interventions that a lot of this is around inflammation, that reduce inflammation, that modulate the immune response, and in turn relieve itch.
Fantastic, thank you. So how would your, I guess, understanding of the etiology, or how would you guide the management when you're starting with a patient?
Well, I think this is then it goes back to the assessment and looking at bloods and skin, and I think this is probably where Robert's going to be really useful, because he will be able to talk to how we mediate this immune response through the use of medications, and things like that. So
fantastic. I'm going to skip. We might flick to Robert if that's okay, and then we'll come back to you in a minute.
Sure.
Thank you so much.
Yes, I'll take a breath.
Yeah.
Sorry.
Let you guys know. So Robert, what would be your first sort of management for patients and looking at the non-pharmacological strategies?
Yes, that kind of extends on what Josh was kind of talking about, that history taking and how that kind of informs what our first steps would be. So irrespective of the cause and the etiology, the standard non-pharmacological treatment would still be recommended for all patients. We know that, as Josh mentioned, that it's often multifactorial, the itch. So the cause, we don't really know always what it's going to be, and often it's a little bit of this and a little bit of that. However, the initial management strategies will really will be underpinned by that initial history taking. So understanding what the triggers have been for that individual, and then mitigating that or the risk of exposure to those. So whether it be allergen exposure or whether it be medications. So Josh spoke about the allergic reaction that can occur with pretty much every medication. However, there are other mechanisms that medications can induce itch. So we've seen more and more oncological medicines that act in an immune manner. They are more likely to be causing itch or systemic kind of effects. So that might not be through traditional histamine pathways that you would normally see, and that would be easily treated as, say, antihistamines. In those situations, we do need to get a little bit more creative with the type of pharmacological treatments that we would go down the path, but we'll talk about that later.
Yep.
I guess from the get-go, like the biggest contributing factor that's often identified is dryness of skin. So mitigating or hydrating the skin as much as possible is probably your best initial strategy, particularly if it's identified that someone has some sort of immune-related past medical history that predisposes them to having drier skin. Then that's what we want to be treating first. So making sure that someone is using the best emollient as possible. So something that's an ointment is usually better because it's a little bit more hydrating to the skin than, say, like a lotion, which is pretty, doesn't stay on the skin for as long, or a cream. So an ointment is usually your first point of call. Avoiding any irritants. So we know perfumes, anything with fragrances can irritate the skin. Sometimes fabric softeners or different types of chemical agents used in the washing process can contribute or make things a little bit worse. And on that low-risk clothing, having things that are like less tightly fitted, cotton, are usually more preferred than having something more synthetic that's going to irritate the skin, or like woolen, for example. Temperature is a big aggravating factor. So showering, or making sure that showers are lukewarm and not extremely hot. Often heat can precipitate out an itch. So that's something that we're a little bit more mindful of. And the general environment. So like I said, generally a cooling effect is found to relieve itch in most cases. There are a few exceptions, particularly in like a neuropathic space. But that would be pretty much the kind of core initial steps that you'd want to be taking or identifying in your initial assessment, and then providing those initial recommendations. So before I deep dive into any of the pharmacological kind of strategies, based on like Josh's assessment, I thought I'll take it back to both yourself and Josh. Is there anything that you would add to maybe that list?
Can I ask, so for not looking at the non-pharmacological, so when would you find the menthol creams and things are most effective for patients, and situations where they would be unlikely to help as well?
Yeah, so menthol's an interesting one because it's one of those that we generally reach for early on, and there's no commercial product, so that's always a challenge. And it does need to be compounded with it's non-PBS, so it's going to be privately funded. So it's something that we tend to recommend pretty early on. But there are a few strategies that you can kind of identify with, or as a predictor to see if it's going to have an effect. So the aim of menthol is as a cooling agent. So if we know that heat is an aggravating factor, then potentially it might have a role at relieving the itch in that situation. The other aspect you can do is like a test almost, like having some sort of like a wet compress on the area that's itchy and seeing if that's relieving the itch. If we're finding that cooling the skin down is relieving it, then potentially menthol could have a role in that space. But the evidence for it isn't high. It's just something that we've done for a long period of time, and it's really by that concept that cooling can have an anti-itch effect.
Fantastic, thank you.
Can I add two quick things in there? The other non-pharmacological things might be distraction, music therapy, some image therapy. And speaking of menthol, one thing that we used in Sydney for people with uremic itch, and this was more from the supportive care, supportive renal care, and I'm sure a lot of people have heard of this, is menthol, sorboline, and some lignocaine, 2%. And we used to mix it in a little specimen jar, and you'd have half full of sorboline, and then the other half was divided in two, which was the menthol and the lignocaine. Robert, I'm not sure if you've heard of this or your thoughts around this. And we'd mix it all together, and anecdotally people felt as though they had a positive response from that, but it was always very difficult to chart, I seem to remember.
I haven't heard of that one before, but I'll add it to my potential toolkit. Thanks, Josh.
Lignocaine is a great one. The only challenge with it is the amount of area that you're applying it to. So if it's localized, it's fantastic. But the more you apply, there is an increased risk of systemic side effects. So we get a little bit cautious about it. Usually the small amounts that Josh is talking about is fine for most people, but you do need to be careful about the extent of the itch.
It was literally the 10 mil that you would normally use to catheterize someone.
Yeah. So it's not going to get systemically absorbed.
No.
Josh, is there any other non-pharmacological strategies you would use? Do you advise that patients anything with, nails or anything apart from what Robert's gone through?
Well, I think, with kids, isn't it, cutting nails and putting gloves on their hands. And usually that's going to be for someone who's got a chronic itch and has been itching for much longer than 6 weeks. So, but I guess that's another thing that you could add on, certainly short nails and I guess it's what's possible for that person, what's not going to impact too much on their quality of life. But certainly everything that Robert said, I would agree with. Yeah.
There's a question in the chat about camphor as well, which is another cooling agent. So that's common, like in Vicks Vapor Rub, and it's definitely an appropriate alternative to menthol. Calamine's another one, but it can have a drying agent to the skin, so it's generally not what I would recommend. The only concern with camphor is that it is toxic. Like, it can be toxic in large quantities. Usually for an adult, it's fine, but in pediatric, it's been reported to cause neurotoxicity in topical applications. So pediatrics is where you'd be most cautious with camphor.
And just, sorry, that combination again was, it's just in the chat. Sorry, Robert. It was sorboline, and this is in a specimen jar. Please don't quote me on this. This is not evidence-based. But in fact, I noticed there's someone from a supportive care, renal supportive care at Concord. Frank Brennan was the one who told me this many years ago. So it was half was the sorboline, and then a 10 mil thing of the lidocaine, 2%, and a little bit of menthol or camphor, any of those sorts of things, deep heat. But yeah, that was it. But yeah.
Fantastic. Can we then move on and talk more about your initial strategies in pharmacological management? And who would like to try and talk first? Josh, did you want to go?
No, I'm gonna.
Sorry,
hand this
no, Robert. Yep.
I'm happy to lead this one, but
Yeah.
it's quite a challenging area because the
Yeah.
recommendations can get quite confusing, and
Yes.
there are different strategies that are coming out. So to go back to Josh's point at the start, it's important to always look up the recommendations. The recommendations are constantly changing. So using CareSearch, the therapeutic guidelines has been updated in the last 2 years, and it's got a nice summary in terms of what we'd recommend in the different types of itch once we know what the cause is. But it can be quite challenging to know what to do first, particularly if you're unclear about the cause. What we generally recommend is trying to avoid throwing the kitchen sink at the issue, because it can be often hard to figure out what's actually made a difference. The other challenge with me saying that is that any treatment that we start can take a little bit of time to take effect. So we're not necessarily always going to be able to establish how big of an impact that's had in the initial kind of stages in the first couple of days. And as we know, working in the healthcare space, we don't often have time. So it's one of those situations that can be quite challenging to navigate, particularly when we're starting to add medications where there are systemic or side effects that we are worried about. So I'm going to try my best to kind of keep the thought process as simple as possible, but basically always treat the cause. So follow the therapeutic guideline recommendations, first-line treatments when you know what or what you suspect is the underlying etiology or the cause, and then make sure that there's a review period for those medications when they are started. So before I go to the underlying etiology, I'll start with the one that we've always been using, which is antihistamines. So antihistamines attempting to use for everybody with any sort of itch. And it's not unreasonable to use, but as Josh has alluded to, it's not always a histamine pathway that's involved. So antihistamines may not always be effective. And the more we are kind of understanding about itch, we're finding that they're less and less effective, and particularly the more we're studying them. So what is the role of antihistamines? The sedating effect can be quite useful, particularly at nighttime, if it's impacting quality of life and ability to sleep. So generally, a sedating antihistamine might be recommended where sleep is impacted by itch at the nighttime. They do have a potential of having an anticholinergic effect, which means that there is a risk of delirium, confusion, particularly in older adults. In some people, that can also lead to or contribute towards urinary retention. So they're kind of the aspects we're a little bit cautious with, and why we wouldn't necessarily recommend it as a blanket. Well, put everyone on an antihistamine at night because it may or may not work. Well, maybe, but it can cause risk. So just be cautious. So that's usually a step one for this when you're like really not sure about the cause, and you might be wanting to see if it will provide some sort of relief. The good thing about the antihistamines is that we generally will get an idea if it's having an impact within a couple of days, if not immediately. So that's one of the benefits of trialing that earlier rather than some of the other types of therapies for the different types of itch. The next, and I will go on to the etiology, but my other disclaimer will be about evidence. So this is a relatively evidence-free zone. A lot of the evidence that we have is based on observational studies, case reports, case series, and really small numbers. It's hard at the best of times to do a palliative care, like a randomized controlled trial or a trial. It's even harder to get a cohort in an itch population, particularly when the etiology does differ and it's not always clear. So that's why this is quite a challenging area to provide any concrete or definitive recommendations, and really goes back to making sure we do that assessment, treating or removing the underlying causes, and then looking at the treatment-specific systemic therapy for refractory itch, essentially, when the initial strategies haven't worked. So the non-pharm strategies in that situation. So that's my big disclaimer. And now the actual treatments. So I guess going back when we're talking about the different etiologies, first ones that we look at are end organ dysfunctions, so particularly those with cholestatic itch or due to liver impairment or uremic renal impairment. So the cholestatic itch, the general recommendations are to start with either sertraline or rifampicin. So sertraline is your antidepressant type medication, and that's going to impact the communication pathways of itch and how it's processed in the body. Rifampicin, the roles or the mechanisms less clear, but it's thought to well, it's been shown in a few small randomized controlled trials to relieve itch and cholestasis. Uremic itch is predominantly nerve-related, so pregabalin and gabapentin are first-line therapies. The challenge is that it's renally cleared as well, so those two medications have high risk of toxicity, and we use very, very small doses in those situations when we're using it. The other therapy that sometimes is considered, and I don't know if this is a Victorian practice, but some services consider using capsaicin, which is like a topical kind of gel that's like a chili-based gel. So it adds heat to the area, and some people find that effective for uremic itch, traditionally also for like shingles itch. However, it's not well tolerated. So most people do experience like a burning sensation that's quite prolonged and can become a little bit painful. So compliance with it is pretty poor. And the evidence for its effect hasn't really been shown. So it's something that's trialed, and sometimes you'll read it in some of the recommendations, but I wouldn't be recommending it as a routine for a uremic itch. The next cohort that Josh kind of introduced was the oncology space. So those with hematological malignancy, often that's related to the actual disease or progression of the disease. So the number one kind of approach would be ensuring, if the person is for further treatment, has that been optimized and been reviewed, because that can alleviate symptoms. Hematologists, as we know, love to treat very, very late into the prognosis. So not suggesting that's appropriate, but that's sometimes a discussion and consideration in their management. Alternatively, it would be high-dose steroids, but again, it has to be in the appropriate cohort that's considered. But steroids are generally quite effective in that cohort. For like your solid tumors or solid malignancies, antidepressants are often considered. So in this situation, paroxetine has the best evidence, and the other one that is sometimes considered is mirtazapine, which is a kind of band-aid for all healthcare symptoms these days. The evidence is a little bit stronger for paroxetine, but not great. And in terms of because with antidepressants, we traditionally have this idea that they take a long time to work, and that's still true in this setting. But usually when we assess it for itch, we're expecting an effect a little bit sooner than you would for, say, depressive symptoms. So you might observe an effect within even a week, and it wouldn't be unreasonable after the week to make a decision whether or not it's had no impact, some impact, and then try your next therapy if it wasn't working. You don't necessarily need to kind of persist with it for as long as you would for, say, other conditions like depression. So I think that's something to note with the antidepressants for itch. The systemic opiates, Josh covered quite well, so I agree. Opioid rotation would be one of your first kind of considerations, particularly if that's a dose-limiting toxicity. The other kind of treatment, if it's really not like there isn't any other option, would be to consider something like ondansetron or a 5-HT3 antagonist, which is the drug class of ondansetron. But that's generally the kind of treatment algorithm for first-line treatments when systemic therapy is being considered for the management of itch for these patient cohorts. And just on the opioid conversion, generally we try to convert to something that's structurally different. So we think of our opiates as synthetic, semi-synthetic opiates, and that's where you'll kind of look at a different one, particularly if you think that there is like a allergic component to it, which can be a little bit less clear, but it's like Josh has mentioned, it's usually other pathways that have kind of contributed to the itch related to opiates.
Fantastic, thank you. Is there any, I guess that's sort of covered our alternative therapies, etc. as well.
There are others, so I'm not sure, Josh, if you've got any other comments about alternative, or I may just put you on the spot. Sorry if I have.
No, not at all. I think it's interesting that you say, the evidence base for this is so little. When I was looking at the latest Cochrane review, which was 2023, I think they said there was a total of, I think it was under 5,000 patients that have sort of been involved in studies for itch. So we're talking very, very small numbers. And I think they included randomized controlled trials. I think they had a total of, in this one, what did they say? They had 91 studies, which was, and of those of different sort of quality throughout. So it is very small numbers that we're talking to. There is nothing in there pharmacologically that was surprising. There are things that we've tried. The only things I would add, I think that I would reinforce is the anticholinergic load that you spoke to, because a lot of our patients are on these medications already, and a lot of them are very frail, very elderly, their renal function's changing, so they are very vulnerable to deliriums, and I think we need to remember that. Going in and reassessing the effectiveness within a short time frame, and that's often where we fall apart, because you might have a GP that's prescribing it, or you might have an oncologist that's prescribing it, or maybe a nurse practitioner that's prescribing it, and then someone's away and we forget to go in and see, was that gabapentin making a difference, or what's it even for? So I think follow-up is really important with itch, because often what we start doesn't make any difference at all, because everyone reacts differently to these medications. And the other thing that we probably should have said straight up is correct the correctable in the first instance, which is, I think, so important with your first assessment to understand, a lot about the person that you're meeting. Not only their diagnosis, but their past medical history, the medications that they're on, their pathology, because there might be something in there that can be easily changed as well. Once again, it would depend on their illness trajectory. Certainly with a cholestatic itch, you'd be thinking, can we go in and, reverse a block, something like that. And that might change the trajectory of that itch really, really effectively without actually having to introduce any medications. So yeah, that would just be the things that I would add.
Yeah, I definitely think deprescribing and monitoring for effect is essential.
Yeah, absolutely.
Okay, so what? Thinking of some complex cases, etc. What would be your strategies? I'm sorry, I'm looking at some of the questions that came through earlier, and then we'll maybe flip to some of the questions online down the track, if that's okay. How would you manage itch that's unresponsive, I guess, to our sort of usual interventions? What would be your suggestions if we've sort of gone through all those different options?
Robert, do you want me to do that first, or do you want to do that first?
Oh, no, I'm happy for you to start, Josh.
Okay, well, mine's very brief. And I think, we're palliative care nurses, we're often dealing with people who are imminently dying. Yes. And so when people are imminently dying, often they can't swallow. So we might be dealing with refractory itch that we can no longer manage with oral medications. And that's when it gets a little bit harder, I suppose. Some might say harder, some might say easier. But certainly I think there's a role for benzodiazepines at that stage when someone is actively dying, last days of life, they have an itch. You would certainly trial a benzodiazepine via a syringe driver, and obviously you'd do that in a very a slow way, but you want to make sure that you explain the side effects of the treatment, that you get consent to these treatments before you start them. I guess the other thing that could be trialed is a lignocaine infusion, and I know there's a lot of stuff out there around prolongation of the QT interval. You're not going to be worrying about that stuff at that time. I know there are some staff specialists that will want a, what's it called, an ECG. I would park that and say absolutely not. But you would be starting at lower doses for if you're just managing itch with a lignocaine infusion as opposed to a lignocaine infusion for pain. So, and probably the same with a benzo for agitation, for distress. You would be starting in larger doses than potentially what you would be for itch. Often patients are already on benzos anyway, but they are certainly for a refractory itch at the very end of life. These might be some of the things that would be doing, as well as Robert was saying, you might change if someone's on morphine, you might change to hydromorphone with the appropriate, dose. Thank you, that word. I was going to say reduction, but I don't want to say reduction.
No, I know what you mean.
Thank you, you know Fantastic. What I mean. So that would be some of that, yeah.
Fantastic. Can I ask, and I don't think it's a silly question, Sarah's asked in the chat, how does camphor work? Are you able to answer that, Robert? Or?
Yeah, so it's a vasodilator, so it increases the blood vessels, and that will then cause a cooling effect, because essentially blood will flow through instead of pooling and causing heat in that area.
Fantastic. And is there any on the menthol and camphor, is there any concerns with, say, broken skin or anything like that, or can it still be used?
I'd be cautious because of sting. So
Yes.
it should be intact skin, like
Intact skin, yes.
Yeah, I wouldn't be applying it to any broken skin. In those areas, it would really be about bandages.
Yes.
And good wound care.
Definitely.
In terms of the refractory, so I agree in the end of life with Josh's recommendations. I might speak to the other side of things because we are getting earlier and earlier referrals into the palliative care space. So ensuring that we do kind of exhaust all of the options. So we kind of get stuck in our bubble and follow the pal care, but remembering that, we do work within a team, and if you've got someone with a good prognosis, making sure that you do involve the right specialists. So just dermatologist involvement, they can definitely pull out more tricks out of the bag than we would in our space. So for people with pre-existing or long-standing itch, irrespective of the diagnosis, if they've got long-standing eczema or dermatitis, there are newer agents, immunological agents that are being used as injections. I've seen them even continue into the palliative space, which can help manage chronic itch in those situations. But they are specialist drugs, so it would need a dermatologist to be involved in those situations. Some additional specialist creams that can be compounded as well, but again, under a dermatologist's advice, and they're all generally immunomodulatory, so they do impact cytokine kind of release, and more useful in those with chronic inflammatory illnesses.
Robert, can I just add, those people that may not have access to a dermatologist, because there'd be plenty of that across the country, I guess going back to your GP in that first instance as well, because they're the primary care doctor, and they would certainly have a wide knowledge base around itch, pruritus, rashes. They'd know their patients really well. Is that something else you'd recommend?
Definitely. And I think even in those areas, they can always direct the care with remote or external advice in those situations if it was required, particularly in those more complex cases. Definitely agree with that. Sentiment.
We don't have to manage everything, do we?
No, definitely not.
Share the love.
The other interesting space is that there are newer agents being available, particularly in the dialysis space. So for uremic itch, so there's recently been PBS listed an injection that's infused with dialysis to prevent itch associated with it. This is my nerd hat coming on, but it's an opioid kappa agonist, which is like a novel type of mechanism that I've never seen before, but it's coming out, and there's more research that's being explored for the management of uremic itch via using an agonist or a mixed agonist antagonist.
Yeah, I was going to say, what's it called? Everyone's going, what's it called? What's it called?
It's called, like, the acronym for it is like DFK.
Okay.
I might post in chat, but I'm not attempting to say it because I'm going to butcher it.
Exactly. Coward. I had to say pruritogens.
Yes.
See the name, you'll understand why I'm not attempting.
Oh, there you go. Yes, it's almost as bad as dexmedetomidine, whatever it's called.
Oh, yes.
Dexmedetomidine, yes.
Thank you. That one.
So can I ask what would be your approach? What can we say, or as clinicians, when we can't ease the symptom burden of itch? What can we do?
When we can't. Gosh, I think there's always something we can do, isn't there?
Yeah.
I mean, nurses, it's never just us. So who else can you involve? Call a friend, speak to family, involve as many experts, get as many voices as you can. But I do think in terms of, when we think about all the non-pharmacological things we can do, and then the add-on of all the pharmacological things we can do, I think there's probably always something we can add. Regardless of the trajectory of that person at that particular time. Sarah's put in there, sleep. If people aren't getting a good sleep, then everything's going to be out of perspective. So, sleep at night might be the time where you do try those medications that are going to cause more drowsiness. It's often why we say start pregabalin at night, whether it's for pain or itch, because it may cause drowsiness. Use your antihistamines at night. It might make people a bit drowsy. Mirtazapine, anxiety, sleep. Lower the dose, the more drowsiness people are going to be. I think, is there anything else you would add in there around, people who can't sleep with itch, Robert?
I 100% agree. I don't think that there's anything else that I would be changing from that perspective. But I will add to your comment about the non-pharmacological. I think it's, in terms of what else we can do, it's that support. So it's that psychological element. We know that is an element like that can make it worse. I'm sure everyone is itching based on this presentation. I am.
Yes. Yeah.
I'm sitting on my hands, so I can stop.
So it's definitely something that we can support from that perspective, having those conversations, understanding that they may be itchy. It's the same as your pain conversations. You will experience pain. You will experience itch. But how can we mitigate it? Decatastrophizing it wherever possible, making sure that, we do trial the non-pharmacological, don't dismiss it. Those simple strategies have been used forever and they've worked. We just need to continue using them and ensuring we are providing that support.
Fantastic, thank you.
Yeah, not deserting our patients. I think that's it. Oh, we're not going to throw our hands in despair. We'll keep coming back to the table with this. Tomorrow's a new day.
The non-abandonment, I think.
Yeah.
We will keep trying no matter what and support. I don't know that there's any particular questions in the chat at the moment. Okay, no, I would not try to say that, Robert. Thank you for typing that in the chat. Is there any other comments from everyone before we kind of wrap up? Or questions that haven't been posted?
I think the obvious one for me would be to involve your pharmacist. Like clearly today is a great example that the pharmacist can give us so much advice around how to manage itch from a pharmacological and a non-pharmacological way. They can also help us look at the medications this person on. Did you think about this? Maybe this is. They can talk to the anticholinergic load that we'd be adding to or taking away from. I mean, the team that have Robert in it are very privileged to have him in it, but our community pharmacists as well, I think we should be really talking to them no matter where we are, and almost as a first port of call in the context of this. The GP, the community pharmacist, really integral to the management of this.
Oh, interesting. There's a question or thoughts on ketamine wafers in renal patients for itch.
I'd say the evidence is pretty low, but probably some anecdotal stuff. Robert, I could be being cynical there, but I have heard of it.
I'm not sure either, to be honest. I've heard of like topical ketamine being used for itch, but I haven't seen it to be effective.
I think this is one of these very niche things that someone's thought they would try and had a good response, and suddenly we're all doing it. So be careful is what I would say.
But I do appreciate the plug about the pharmacist, Josh. Thank you so much.
Not at all.
It does help us as well. I think in the community particularly, they can feel a little bit isolated and not necessarily involved in the conversation as much as, say, the palliative care nurses are. So even when you've identified someone with an itch, notifying them so they can have those conversations goes a long way.
Yeah, definitely. The places I've worked with a palliative care pharmacist or, of course, community pharmacists, the benefit is unlimited. Having someone who's supportive,
especially with palliative care patients, because we ask a lot of our pharmacists. Suddenly they're getting a lot of medications they haven't had to get before. So certainly, any palliative care nurse and certainly nurse practitioners should be making relationships with their pharmacists as well, because they often don't know what we can and can't do. So there are so many there are far more positives than negatives to those conversations. I can't think of any negatives. Yeah.
Well then, first of all, so thank you very much, Josh and Robert, for your time today and for sharing, your expertise and insights. I've taken a lot from this session and, very kind of inspired, and I'm sure all the attendees have as well. Thanks everyone for joining us this afternoon. This recording, will be shared for all registered attendees and will be available via the PCNA website and YouTube channel. And then upcoming sessions, the PCNA webinars continuing in 2026, and the next session will be on Wednesday, the 19th of August, which is the very interesting topic of palliative care in humanitarian crisis. Feel free, obviously, to pop any questions through to James in the admin at pcna.org.au. Thanks everyone for your time, and look forward to connecting to you again.